Hi, my name is Jackie Whittemore, and I am excited to have you join me for my first Vice rounds. I picked Polyuria polydipsia as a topic because it is an extremely common presenting complaint in general practice. To be honest, I also picked it because it was the thing I thought I could most quickly get ready to get in your hands to help continue your education. When confronting cases who have PUPD, there are a number of different things that you need to consider, and this is going to be a little more subject to time sensitivity in private practice because generally, when I was a general practitioner before I specialized, I saw about 14 to 16 appointments a day in addition to surgeries and drop-offs, and at least a couple of them every day would be presenting with PUPD. So you need to be able to turn it around relatively quickly and have an informed discussion in the moment about the most likely things to be able to stay on track in your schedule. So when evaluating your patient, you need to have a ready understanding of the hormonal mechanisms of water balance because it's going to influence the differentials in your individual cases and so what you're going to recommend for evaluation. List factors that are going to contribute to urine concentration and dilution to help pick among your options, and list the most likely differentials for PUPD and their mechanisms of action in a dog or a cat. This is important because common things happen commonly, and so usually this is going to be what's going to inform your immediate plan or help you decide where to start. Additionally, knowing the mechanisms of action is going to be really important in helping the client make the right choice when they ask you things like, the animal is making us crazy and we can't sleep at all at night, and so can we cut back water intake at all during the day so that we don't lose our minds. Now, all of that is kind of what you need to have in your back pocket to get through the day, and then things loosen up a little bit because you're going to send the client away, you'll get back your testing, and then from that you're going to interpret your initial workup to figure out, wow, did a common thing happen commonly in this case, or am I going to have to look a little further? What do I need to do about this? And if it isn't a common thing, what additional diagnostics do I need to look at doing? So let's go ahead and start at the beginning of the things that you need to know right away. So this is a great image out of Gray's Anatomy. This is from the edition published in 1918, so it's considered common use. It's covered under common use. It's not covered under copyright, and which is pretty amazing. And what we can see is in over 100 years, we've had basically no change in our understanding of the nephron. We can see we've got the glomerulus, and then it curves around through the proximal convoluted tubule, down to the loop of Henle, comes up into the distal convoluted tubule, which is now sort of the irregular tubule, and then over into the secondary convoluted tubule, which connects into the collecting duct, and then into the collecting tubules. You can see here is the gradient in the medulla. So if we think about things that control water homeostasis, although we want to jump right into the kidney, the reality is we have to step back because water control or control of water balance in the body really starts way up here in the brain in the tiny little section, the pituitary. So what are the three things that you have to have in order to maintain good water homeostasis? Well, the first is going to be appropriate pituitary function. And because it's the pituitary that is going to be releasing antidiuretic hormone to act down here at the collecting duct to cause insertion of aquaporin 2 channels and allow water resorption. You also have to have an appropriate response of the collecting tubule to ADH in order for it to do its job, and this means that you have to be able to insert those pores in response to appropriate binding. And finally, it really doesn't matter if you insert the aquaporin channels and create the pores if you don't have an appropriate medullary gradient, because what we're counting on is water being pulled into the interstitium because of appropriate laws of diffusion and osmolarity. And so if you don't have appropriate concentration in the gradient or otherwise have too much stuff going on, like too much solute in the filtrate, then that's going to hold water in place. When we think about that water homeostasis and step back a little more, the really important thing about that gradient is we think is that blood is coming in from the efferent arteriole, and then it's going down into the vasa recta and coming up into the vein, and at the same time it's sucking water out as it goes down, and then you end up with sodium being sucked out as it goes back up, and water being sucked in as it goes back up. And the net result, if we look over here at the nephron on the right, is that we can see that the filtrate that enters the nephron through the glomerulus starts at the same tonicity as plasma. So it's isotonic to plasma, which would be in the simpler terms, if we were to look at it in sort of urine terms, that would be isosthenuric. So isosthenuric means that you have the same tonicity as blood. That curves along here, and because we see water is coming out of the vessels into the interstitium on the way down, that and sodium is being taken up in the vessel, that's coming out in concert with things being pulled out, going downward in the loop of Henle. So water is coming out, but that is happening in association with filtrate. And so what you end up with is that you end up with super duper concentrated urine down here at the very bottom, because all this water is getting sucked out because of sodium that's been created by this gradient, right? So we're down here to that 1200. And so what you end up at the very bottom of the loop of Henle is super concentrated urine. So it's hyperstheniuric. And then as you get thickness in the ascending loop of Henle, that prevents water from being able to come out. And so sodium gets sucked out into the interstitium. And by doing so, we go back to being somewhere right in here to being isotonic, but we go way past that so that actually fluid in the collecting duct starts dilute compared to plasma. So fluid here would technically be considered hyposthenuric. And then you say, well, wait, it's hyposthenuric. Well, yes, the kidney did its job and it actually made it really dilute compared to plasma. And then the body decides, do I want to leave it that way, or do we need to hold on to water? And so then this is where ADH binding comes in and allows the water to get sucked back in, so that you end up again at the very end of the process with super concentrated urine. The other thing, one thing that's missing off of here is going to be BUN is not being shown on this graph. You can just see sodium movement, but that BUN concentration is going to be really important to the medullary concentration. So to recap again, we're starting isotonic or isoosmolar. That code takes us way down here to being hypertonic or super concentrated. Then as we ascend all the way back up to the start of the collection tubule, we end up hyposthenuric. And it is only through the action of ADH that then we end up with concentration of urine for super concentrated urine. The upshot of this, or the important ramification, is that if you see a patient with hypostenuria, then that tells you that the nephron is functional. It tells you that the tubular cells are functional, and so it's simply impossible to have hypostenuria in an animal that has chronic kidney disease as the cause of their PUPD. Because if they had chronic kidney disease with poor tubular function, they would never be able to get concentrated, and if they cannot get concentrated, they cannot make their way up to being dilute, because we get loss of the function of this gradient. So clinically, the ramification is, although chronic kidney disease is one of the most common causes of PUPD in both the dog and the cat, and also it can be really hard to determine that that's really what's going on, since loss of concentrating ability precedes development of azotemia in most cases. If you get hypostenuria on your urine analysis, then you know that is not your problem. And so it's a really powerful thing to note. It completely changes your potential differential list. So to recap, you have to have appropriate pituitary function, appropriate tubular response, an adequate medullary gradient, and that again is hinging on having what you need in the medulla, so sodium and BUN, in order for it to work, but it also is dependent on what's in the filtrate. And so if you have a whole lot of solutes in the filtrate, again, like the chronic kidney disease, when we're not appropriately resorbing them, or something like diabetes where there's a lot of glucose in the filtrate, then it can't work. You don't have an appropriate gradient and water cannot get sucked out. Okay, so take a minute here and either as a group or using your individual worksheet, I want you to work your way through how lab work would differ between a dog with normal concentrating ability that is hydrated. So what would their ADH level be? What would you expect urine concentration to be? What would you expect their plasma osmolarity to be? All of those things. And then think about how that would look different in contrast to a dog that has a normal concentrating ability but is polydipsic because of dehydration or use. So if you have a dog, for example, that's been doing a lot of training, it's been doing a lot of running outside with its owner in a dry climate, and so then it's drinking a lot because of that, because it's having to catch up for those respiratory losses. So how would their hormonal levels differ? How would their plasma osmolarity differ? Things, all of those different factors. I'm not going to pause and leave you in awkward silence while you work on this, because every group is going to work differently and every person is going to work differently. So please go ahead and wiggle your mouse and then you can press the pause button to work through this before moving on. Okay, now that you're done with that, I want you to continue your discussion by thinking about what other factors might be out there that affect urine concentration. What specific details do you need to collect from owners in order to assess any lab work results that you get? Right? So this is something, again, I want you to take a minute and pause and think through it yourself. What are things you can think of that are going to influence concentration? What are details you need to collect from owners in order to be able to interpret that urine concentration or interpret those clinical signs? So go ahead and pause again. And now we're back. It's great to have you back, and so we're going to go ahead and move on. So to talk about some of these things, I want to talk about those. I want to talk about those other factors because this is so important to getting a good history. And to illustrate this point, I am going to take my parents' late dog, Glenn here, who was never ever good at hunting but accidentally killed a baby bunny rabbit once. He mourned for several days. But I'm going to take Glenn here and we're going to put him in a couple of different places. So if we take Glenn and we take him to Colorado. So this is a picture I took while hiking up a 14er with a hiking buddy. And we took him up here onto the mountain to go hiking with me and zooping along. The ambient humidity up here is basically negative. And so to do a simple hike, not staying out there, not carrying major pack, it would be very common for me to go through 4 or 5 liters of water in order to avoid getting dehydrated. So if I have Glenn there, he is going to need a pack of his own with lots and lots of water. He's going to be drinking way more water than normal in order to compensate for the combination of exertion and ambient humidity. So we'll put him over there, and there he is. And now, boy, he's going to need to have his own backpack. In contrast, after I did my residency, I moved to Tennessee, and now I have the privilege of doing my hiking in the Great Smoky Mountains. So I'm still hiking, and if I were to take Glenn, not into Smoky Mountain National Park because dogs are not allowed there, but if I were to take him into sort of the same area, and we're going to go hiking, even though we're both still exerting ourselves quite a bit going up and down, the reason it's smoky is because of all the moisture in the air. So we no longer have those same issues of negative ambient humidity. So instead of me needing to have 6 liters of water for a 18-mile hike or 16-mile hike, generally 1.5 liters of water is more than plenty, and I'm going to have some left over at the end of the day. So if I take Glenn there, then even though he's doing the same level of exertion, he's going to need a lot less water to stay hydrated. So thinking about ambient humidity, thinking about exertional exposure, these are all going to be important factors in talking to your humans. I also need to think about whether they're sick. So if I have a dog that's been throwing up everywhere, like this St. Bernard here, then he's going to be needing a lot more water in order to make up for those losses. Or if I have a cat that has developed pretty bad diarrhea for one reason or another, then certainly she's going to need to be drinking a lot more water to keep from getting dehydrated. And so her water intake is going to be a lot higher. Now, there are other factors that are really important to consider as well. So emotion is going to be a big factor. So if you have an animal that's really bored, it's living alone, and it lost, say, a housemate and it's just living alone, doesn't have anyone to play with, then it can get bored and end up playing, drinking just out of boredom. And some of us can probably identify with this being on home isolation. Some of us, like myself, who have a 5-year-old, do not find ourselves to be bored, but also probably have interest in drinking games at this point. Now, the other thing that can happen, and that's really a good example of the other problem, which is that animals, just like people, can drink out of stress. And so I don't know a lot about stress management, but I know a lot about drinking. So if you have an animal that's gotten really stressed out due to something going on, that can cause a big shift in water intake. And I have this really amazing and excellent example of this. It was a case that Shelley Olin, one of my faculty mates, saw in the clinic, and there had been a little bit of a miscommunication, such that when the dog was dropped off, the owners had brought a urine sample. So at noon, the owners dropped the dog off and they brought a urine sample with them, and that was submitted by the technician on the service for urinalysis. Well, the student did not realize that a urine sample had been collected and had already been turned in, and so they were able to collect urine 3 hours later. So the dog has been in the clinic hanging out for 3 hours in a cage or a run, and they took it out to walk and got a urine sample, and look at the drop in urine concentration there just from the stress of hanging out in the clinic for 3 hours. So the dog dropped from 1043 to 1007 in 3 hours. And this really gets to the importance of taking care in interpreting urine concentration in samples that are submitted, that you collect yourself after having animals in the clinic, or in animals that have a stressful situation at home. If the owner is collecting urine later in the day, you can have that same problem. Long story short, a big way to take this out of the picture is do what they did, which is to collect the urine at home. Ideally, first voided urine sample, because they haven't had time to be stress drinkers in the middle of the night, and save that and use that to answer the question, are they polyuric polydipsic? Or perhaps they might be polydipsic, like this guy, without having polyuria. The last thing that's super important to keep in mind is the impact of diet. So if you take cats and you feed them a solid kibble, then they can have super concentrated urine. This is partially believed to be that cats are obligate carnivores, and so they historically have gotten a lot of water intake evolutionarily from their prey and did not have the same pressures on them to develop a thirst drive. And so cats don't have as strong of a thirst drive as dogs. So if they are on kibble, they may often concentrate really, really high. If, however, they are on a slurry, like this one here that Tigger, a former patient of mine, was on, then they can have much less well-concentrated urine, not because they're drinking more, but because they're drinking the same amount, but they're getting additional water through their food. And then this cat, Elise, who is my personal cat, when she was fed a home-cooked pate, she's somewhere in the middle, right? And so here is another good example. These are 2 UAs from a different cat of mine, Cecil, and the UA on the right is taken when Cecil was receiving a kibble diet. But Cecil, on his kibble diet, developed clinical signs of feline interstitial cystitis, and so he was placed on an all-canned food diet. And when Cecil was on an all-canned food diet, with no change in his water intake, his specific gravity dropped from 1060 to 1026, and his clinical signs of FIC resolved. If, however, we try and wean him back onto any dry food, his concentration goes back up, and as do his clinical signs. So knowing exactly what an animal is eating and all types of things that the animal is eating make a big difference in trying to interpret concentration. So all of that said, what would be considered abnormal? Well, A water intake greater than 100 mils per kilo per day would be considered abnormal, and urine output greater than 50 mils per kg per day also would be considered abnormal. But the reality is, it's the yin and the yang, and so we're looking at them in combination. As we said before, an animal can be polydipsic without having a urine concentration problem if they are having water loss through their respiratory system or through GI loss or something like that. But you cannot generally have true polyuria in absence of polydipsia. So trying to interpret these absolute numbers gets really complicated because it's all very contextual. And the long and the short of that is that means that abnormal is not the same as inappropriate. Normal, again, is depending on the circumstances. So let's go ahead and get our papers back out, or get ready to hit the pause button. Well, get ready to hit the pause button no matter what. But get your papers back out, or get with your buddies and unmute your Zoom session so that you guys can have a chat and think about if isolated cutoffs, so if we can't just say water intake greater than X or urine output greater than Y, cannot be used to make the diagnosis, what can be used in their stead? And take a minute and let's think about it. Great. Now that you guys have a good sense of what you think works there, go ahead and think about what of all the things that you discussed would be the single most helpful piece of data for determining if PUPD is present. So what is the single most important thing to have to determine if the syndrome of PUPD is present? Okay, so let's see. So what is abnormal? Well, abnormal would be considered increased water intake or urine output for that animal in the presence of a persistently low specific gravity. So that's one working definition. So they've got increased water intake or urine output in the presence of a persistently low specific gravity. You'll know we didn't say dilute, because a lot of PUPD is actually isosphenic. So just low. Or inappropriately unconcentrated urine given the animal's physiologic state. So this would be that it is inappropriate for an animal to have a specific gravity of 10-15, which is partially concentrated if that animal is dehydrated. So having a 10-15 with hydration, that's totally normal. That just means the animal just felt a little thirsty. Having a 10-15 with dehydration, however, would be unacceptable. So either of those things would be considered abnormal. The big thing, and that most important data point to help you make these calls, the absolute top thing you need is you need to have a first morning urine sample. That's going to be crucial because that is taking out the possibility that polyuria is due to psychogenic polydipsia. So that we're taking out the possibility to the best we can that it is because of drinking from boredom, drinking from anxiety, or drinking from stress. So that's that whole combination of the yin and the yang. Now, once we've decided that it's abnormal, that we do in fact have PUPD in a case, then we have to think about our differentials. And this is the list. So, and of course there's probably something new or will be something new, but right now it's pretty well, there's 29 causes that are pretty well agreed upon, and this is the list here in alphabetical order. The list can be broken down to evaluate things by mechanisms. So why or how is a disease causing PUPD? This is very important when you're trying to decide about patient care and management. So deciding what they need to have done and deciding whether water restriction is something that could be considered or would be catastrophic. But this is a really hard way sometimes to think about things in the moment, because it's remembering 29 things in alphabetical order is useless. Remembering things by mechanism is complicated by the fact that a lot of differentials for PUPD cause it by multiple mechanisms. And so the other thing you can consider is just breaking it down by anatomy to try and help you just remember the list. So it's just, that's the way to help you with basic recall. So We're going to start by talking about those mechanisms. And so if we think about the mechanisms, the first mechanism is going to be primary polydipsia. So this is a problem in the brain. And this is Brain from Pinky in the Brain, and I just got his picture off of Google. And so primary polydipsia can be psychogenic, which can mean that they're crazy, as it were, but it can be because of boredom, anxiety, pain, or nausea. It also could just be a thing. It can occur as a component of liver disease, and that is going to be true for like hepatic encephalopathy is causing a primary polydipsia. And then primary polydipsia also is believed to occur or has been shown to occur under differing circumstances in cats with hyperthyroidism and in patients with gastrointestinal disease. For the GI disease, this can just be if they have true polydipsia without PUPD, because they're catching up with water intake. But some animals with gastrointestinal disease will get truly PUPD, probably because they're having polydipsia to offset nausea. Now, if it's not a primary polydipsia, given that it's the yin and the yang and they have to be found together, then the problem is polyuria, in which case they're drinking to keep up. And so primary polyuria can be broken down into three mechanisms. The first is that there is no ADH, so reduced or absent ADH production by the pituitary. This is going to be the syndrome of central diabetes insipidus. It can be congenital, or it can, in young animals, it can occur due to neoplasia, such as pituitary-dependent Cushing's disease in old animals. It can occur in people with head trauma, because you can have severing of the pituitary from the brain. And then there are a number of other diseases that act upon ADH release in the brain, including pheochromocytoma, polycythemia vera, and splenomegaly. And it also can just be idiopathic, where you've ruled all these things out. There's no head trauma. You do a CT. You have no evidence of neoplasia, but it is late onset, so it's not congenital. You can have loss of a gradient, which is preventing the body from being able to respond to ADH. So even though ADH is being released by the brain and binding at the kidney, it isn't working, and that's going to be because there is loss of gradient. And that can happen because of washout secondary to chronic PUPD, i.e. something else caused the PUPD and now there is no gradient, so even though the primary problem is gone, it's still here. It can happen with diuretics. It can happen with fluid therapy. It can be that the patient has a hyponatremia, has hypoadrenocorticism, which acts partially by hyponatremia, but partially from a different mechanism, or has liver failure or portosystemic shunting, which is causing failure to produce BUN. Because remember, the filtrate or the medullary gradient is primarily comprised of BUN and sodium. Or you could have an inappropriate response to ADH. So the ADH got out of the brain, the gradient is ready to do its job, but ADH is either not successfully binding in the kidney, or things downstream from it binding are not working. So this is also classed as nephrogenic diabetes insipidus. It can occur as a congenital or primary disorder due to absent or dysfunctional ADH receptors. Or it can be secondary. And things that it's secondary to, it can be due to an osmotic diuresis, like diabetes mellitus, where the glucose in the filtrate is causing an inappropriate response to ADH because it's holding water in the lumen. It can be that there's an impaired cellular response to ADH, which is what is seen, or one of the mechanisms for Cushing's disease, or high calcium. High calcium antagonizes ADH binding, as does excessive steroid. And it can be due to downregulation of aquaporin 2 channels. So if the body's not making them, then even if ADH binds, they can't be inserted. And that has been seen in association with low potassium or ureteral obstruction. So again, those are our mechanisms, and they're going to be important for influencing our patient care, but it's not really going to help you when you're sandwiched in between 4 well puppies and kittens, a puppy that comes in with parvo, a dental that you need to do, and you suddenly have a PUPD case on your schedule. And so then your big thing is you want to kind of be able to figure out the top differentials for the patient so that you can figure out the right test to consider. And when I was a student, actually, when I was on medicine, we would be in groups of like 7, and we would sit in rounds, and they loved to say, okay, we're going to go around the room and everybody name a differential. And we'd go around the room, and I remember doing PUPD, and I was like number 6. And that was okay, because there were 29 causes. But when we ran around the 3rd time, then I'm at the very end of the possible differentials and just basically hysterical. And so it took me a long time. I actually managed to get through being in general practice, through my residency, through my PhD, and was faculty before I finally figured out there was a way I could keep track of all the differentials instead of having to panic and pull up an article or hide a list in my lab coat. And that was by doing something that I call walking the dog. And this is something I've described to students at UT for a number of years. And at one point, a wonderful student named Faith Cogwell, who in her previous life had been a graphic illustrator, made me a dog, because it's so embarrassing how bad my ability is to draw them, that she decided that she should just provide me the dog. And so this is the dog. And so what I do is I just start at the tip of the nose and work my way down the animal, all the way down from the tip of the nose to the tail, and circle through or cycle through all the possible differentials. Of course, it does take a little bit of doing this in order to get the hang of what they are. But if you think about it, it's not too bad if you remember that anything that is an endocrine organ probably contributes, and anything that is paired contributes. And then there's a couple other things that you have to figure out on the way. And what I do is generally, as I'm sketching it out in that, I always forget at least one, and whatever I forget, I just substitute an alien baby. And this actually is a picture of the whiteboard. One of my students at the time, Carolyn Aldrich, who has gone on and done a medicine residency of her own, this was her determination to walk the dog by herself. And you can see, in honor of me, when she couldn't remember one of the differentials, she substituted alien baby. And eventually she figured out she was missing polycythemia. So I want you to take a few minutes, pause the lecture, and take a few minutes and working either as a group, or if you're doing this at home alone, you can go ahead and sketch yourself out a dog, and working head to tail, try and jot down all the differentials you can just recall off the top of your head for a PUPD. Now, don't go cheat. And looking back at previous parts of the video, I want you to really try and push yourself and see, if I just think through things that I know and mechanisms I know, what can I come up with? A pro tip, again, is almost everything that is a paired structure in the body is going to contribute at least one differential. And then for big organs like the kidney that have lots of differentials, if you break them down into sub-anatomy, that will help with recall. So I'm going to tell you right up front, there are 11 differentials in the kidney. So if I try and think of 11 things all at once, that won't work. But if I try and work my way through and say, what if there's a problem at the tubule? What if there's a problem in the filtrate? And like that, and break them into sections, then it makes it a lot easier. So go ahead and pause me and take a minute. Awesome. Well, I'm sure you all did amazing, and you probably got it, way more than I used to get when I did this. I still actually do this. I'll tear out when I'm working on cases with students, I'll tear out a paper towel and just write down 1, 2, 3, 4, 5, 6, 7, and work my way head to tail myself. And I find that it helps me. And this, if you do that and you're working head to tail, this would be your list. So we've got 4 that are in the brain. So we've got cerebrum, is where I put primary polydipsia. Then we've got 3 in the pituitary, so CDI, hyperadrenocorticism. Now I know it also occurs in the adrenal, but this is the first place I run into it, and so that's where I put it. And acromegaly, which is going to be a big issue in cats. Then I'm going to run into the thyroid-parathyroid complex, and so then I have hyperthyroidism and hypercalcemia. Again, I know hypercalcemia can occur due to things other than hyperparathyroidism, but I put it there because that's where I run into it first. I like to put polycythemia in the chest, and that's mainly because I feel sorry for the chest, but also because I know that, like, if I have reverse heart shunts, that I can have issues with polycythemia. If I have really severe pulmonary disease, then I can end up with polycythemia. Technically, that's not polycythemia vera, the syndrome, but severe erythrocytosis, like you can see with that kind of reverse shunting, or severe infiltrative disease in the lungs also can result, the severe erythrocytosis associated with those things can cause PPDs. So that's where I put it. Immediately behind the diaphragm, I run into the liver. So that's where I've got portosystemic shunt and liver failure. The liver abuts the pancreas, which gives me diabetes, and the spleen. And then I hit the adrenal gland. We already have Cushing's up here. So working GFR and then the medulla, I've got the remaining ones are going to be hyperaldosteronism, which is a big thing in cats, hypoadrenocorticism, which is a big thing in dogs, and pheochromocytoma, which is going to be old dogs. Now I hit the kidney with its 11, and you can see I've got sort of my general kidney function or nephron function, my infections, pyelonephritis. Lepto I do separately from pyelo because it has been shown to cause pure PUPD without any evidence of sepsis or kidney dysfunction otherwise, and so it gets its own number. Primary nephrogenic diabetes insipidus, which is a congenital disorder. This is the one I always forget. Hyponatremia, hypokalemia. Fanconi's, so now I'm getting into my tubulopathies, so Fanconi's and primary renal glucoseuria. And then finally, post-obstructive diuresis, which is going to be an issue. Generally, we're thinking of this going to be in like cats that had a calcium oxalate stone obstruction that you did not know about, and then they passed it, and then we get the post-obstructive diuresis or a medullary washout. Partial ureteral obstruction, so they've got stones still in there, and that back pressure from the ureteral obstruction causes downregulation of aquaporin 2 channels. And then the weirdos, so intestinal leiomyosarcoma, sepsis, our big ones we think of are like an open pyo or chronic prostatitis. I've seen this with cholecystitis several times, so it can be any chronic septic state. And then of course drugs, diets, and toxins. So that is going to be my full list. I'm not expecting to anybody, any student or other, to have this list memorized. There's a reason that we have, we've got better things to do with our brain than memorize lists. But you need to be able to generate the list or know the list or know where to find the list. And then in the immediate term, really what you need is to know common things occur commonly. So what are those common things? So in the dog, our commons are going to be Cushing's, diabetes, and kidney disease. These are the tops. Most PUPDs are going to be one of those. And in the cats, it's going to be hyperthyroidism, diabetes, and again, CKD. So when I take my list of 29 things, my big focus is in narrowing the list. And I actually can do a massive amount in narrowing the list just with signalment, history, and physical exam. And then I'm going to throw in a urinalysis, but I'm going to make sure if they presented for complaint of PUPD, if we see that on the schedule, that when they call to do an appointment confirmation, that we ask them to bring in that first voided sample of the day, because that's going to really help me to say hypostenuria versus isostenuria, or if it's well concentrated, that's going to really push me to say, hey, I believe you got well concentrated urine. We need to be looking for a polydipsia disorder. And whether that's a PUPD that's a primary polydipsia, or whether it's polydipsia because of water loss elsewhere, that's going to be my next step. Once I have that information, I'm going to really have slashed my list way down, as I'll show you in a minute. And then from there, generally, your minimum database is going to be a complete blood count, biochem profile, a T4 in a cat, SDMA, a blood pressure, and a urine culture. The one of interest on here, or worth talking about just for a moment, is blood pressure, because we're not generally looking at blood pressure, although although there are theoretical studies that say that hypertension can cause diuresis, it does not seem to apply clinically. And so the big reason that we're looking at blood pressure is not that hypertension itself causes PUPD, but it's that diseases that cause hypertension also commonly cause PUPD. And so that's going to help us to narrow our list of diseases. My tier 3, as it were, if my tier 1 is a signalment, history, examination, and urine-specific gravity first morning sample, a tier 2 is my minimum database. My tier 3 is going to be things like imaging, bile acids, adrenal function testing, lepto testing, things like that. And what order you're going to do those in, of course, is completely case dependent. If I have done all of these things, all of them, and everything is normal, what's going to be left? Well, what's left is going to be assessing GFR. And if you haven't done an STMA, because you don't have that as part of your standard workup, obviously you do that. And then the old system used to be that if they passed GFR, the next step was a water deprivation test or a modified water deprivation test. Because all that's left, if you've done all the other tests, the only things really left to you are CDI, NDI, and primary polydipsia. However, this is a very dangerous test. If you get distracted, let's say you're starting a modified water depth test and suddenly a dog comes in with dystocia or it's ruptured a chordae and it's in immediate distress and the clinic gets distracted with it, the dog runs out of water or misses its weigh-in, its 1 hour weigh-in, they can be life-threateningly dehydrated and die very rapidly. And about once a year we get a call on the consult line of what to do to try and save a dog that's been in this circumstance. And so for that reason, these are not recommended anymore. They're actually should not be done. And instead, after you've ruled everything else out, then we consider a DDAVP trial. And again, this is only after everything is ruled out. So I said that like twice, 3 times in a row. So why don't you pause here, and I want you to as a group or by yourself think about why must you delay testing for CDI until after all other differentials have been ruled out? Why is it essential that you always rule everything else out before you do a desmopressin trial? And once you've thought about that, then I want you to think about what would be the consequence of misdiagnosis. So what happens if you do things out of order? What are going to be the consequences of that to the owner and to the animal? Now, you'll notice that there have been a couple of these comprehension checks where I've asked you to talk about some things, and those are not things I've gone on to answer for you. And this is going to be one like that where I'm leaving this for you to work with as a group, and it's part of your, or if you're doing this at home on your own and writing down your answers, this is going to be your graded work to allow assessment of your effort. So, I'm going to leave you hanging with this one, but I promise you can figure it out. So what is a DDAVP trial? Well, what's done for this is the first phase is that you do nothing. And actually the owner has to do all the work. They do a 24-hour urine osmolarity or urine collection at home. So what they do is the animal is allowed to continue to have everything just normally, and the owner gets 11 little tubes, and they collect urine every 2 hours during the day and every 4 hours during the night for 24 hours. And then the samples are sent to the lab for measurement of urine osmolarity. If there is a strong fluctuation in urine osmolarity and or one or more samples have an osmolarity greater than 1,000 milliosmoles per kilo, that is consistent or diagnostic for primary polydipsia. Now, if that is doesn't happen, if it's a flat line and it stays unconcentrated, then you go to phase 2, and during phase 2, the owners administer 1 drop of DDAVP 3 times a day in the eye, in the conjunctival sac for 4 days, and then on the 4th day, they're going to repeat the urine sample collection. And with this test, with both complete and partial CDI, PUPD should cease after administration of desmopressin and urine osmolarity rises. If it does not, that would be consistent with either a primary NDI or a primary polydipsia. And you're going to use your patient particulars to help differentiate the two. Now, I walked you through all this, but let's go ahead and let's see. I promised you I'd show you how much you can rule out at each step. So let's do it with a case. So this is Stella, and Stella is this 13-year-old female spayed hound mix. She has an acute onset of PUPD. She's presented for acute onset of PUPD. It is a 2-day duration with increasing severity, and she's been having accidents in the house, which she never did before. She also is reported to have a 1-day history of anorexia. Okay, so if we take our list and we look at our list, so we know she's a dog, we know she's old, and we know that that she's receiving no medications. So if we know that, we know she's a dog, so it's not going to be acromegaly or hyperthyroidism, pretty much, because those are cat things. Hyperaldosteronism, again, is a cat thing. I did a physical exam, and I know she doesn't have a big spleen. She's old, so she can't have congenital nephrogenic DI, and I know she's not receiving any drugs or dietary issues that would cause the problem, like protein restriction, but I can't rule out toxins, right? Because she's a biggish looking dog, so I'm pretty confident she's getting walked outside. So here we go, 1, 2, 3, 4, 5, 5.5 things, bam, gone, and all we've done is an exam. So then I can, oh, I'm sorry, I forgot. The other part of her exam was I noted she had abdominal pain and fever and a large bladder. So large bladder is helpful to note, right? Because if you have an animal presents for PUPD and you can't get urine on them and you have to keep them during the day to get urine on them, that suggests that probably they're not PUPD. They might be polyuric, but they're probably not PUPD. This also is really pointing me that to say, this is not going to be a CKD case or a Cushing's case, because neither of those are things that are going to lead me towards fever or abdominal pain. So on lab work, she has a specific gravity of 1002. That's going to be really important to me. I'm going to go, whoa, that is hyposthenuric, which means that she's got normal nephron function, and she's neutrophilic. So if I go back, I know that her CBC was otherwise good. We know her chem is normal because these are her only abnormalities. And on her urine, her only abnormality was her hypostenuria. So if I go back here, boom, normal calcium, that's gone. Normal red count, polycythemia is gone. Normal glucose. I know it's not CKD. I know it's not an AKI where she's having nephron dysfunction because she's hyposthenuric. I know it's not her sodium. I know it's not her potassium. Again, I know she's got no glucose in her urine. And I know she wasn't obstructed. So I know it's not a post-obstructive diuresis. Whammo! So I have, with just adding a minimum database, I've now taken 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and now I've taken the toxins off because most of them act with things like AKI. 16 things. I've eliminated 16 differentials in this case just with a minimum database. And so what do? Do I go to the owner and say, oh man, I didn't find anything. We're going to have to do more tests. I say, heck no. I would go to the owner and I'd say, great news. We've ruled out 16 things. We've got a few things left on our list that we're going to need to work our way through. You'll also note I still have some things on this list that I know are probably not true for this case. So I do not accept that this dog has Cushing's disease. I didn't strike it out because I haven't proven it. But I'm certainly not going to be chasing that right away. I know it's, there's a ton of these things on here that I'm going to say, this isn't on my list. But to be fair to you and show you, these are the ones I can prove she doesn't have so far. So what did we actually find? Well, Stella ended up having sepsis due to bacterial enteroinvasion and an underlying previously undiagnosed chronic enteropathy. And so she had to be treated with antibiotics for her sepsis, which immediately cleared her PUPD, and then have long-term therapy with a hypoallergenic diet to prevent recurrence. And anytime this dog happened to have a deviation from her strict diet trial, if she stole something when she was out with her owners, then she would relapse and get very, very sick. And I know this, and I know that they were very strict because this was actually my dog and my sweet Stella, who has gone on and is currently in heaven, but had a good run of it. So I thank you very much. I hope you have enjoyed this digital clinical case experience, and it will help you grow during these unprecedented times. I also want to thank the educators at University of Florida for initiating this VICE crowdsourcing education. And if you are a veterinary educator and want to upload your rounds of your own, here's the email for contacting them. I can tell you this really wasn't hard at all. And if you have any questions, I'm happy to give you input on things I tried. Please do the 5. I've adjusted it a little bit, so wash your hands often. The New York Times has contracted with Broadway songwriters to develop some new songs so you don't have to sing happy birthday. And make sure to stay more than 6 feet apart to help avoid a spread of the disease. And with that, I want to thank you, and I hope to have more of these for you, and I want you to know that I'm really excited and proud of you continuing your education under these circumstances. Take care.